Congratulations, Dr. Christensen. I just saw your paper in Annals of Surgery about the nurse-led clinic for LARS. Can you tell us a little bit about the framework and how the clinic works?
Of course I can. I'm very proud that we have had these results out finally. Actually, this is should be seen in the whole idea that we're actually doing screening for late sequelae following our colorectal cancer patients in Denmark now, where we send out questionnaires every 3 months, 12 months, 24 months, and 36 months, and thereby get the patients to respond back if they have need for treatment. And within this initiative, we have recruited patients with rectal cancer to our clinic, more than 200 patients in need for treatment. And we have set up an algorithm how to treat those. And this is a written algorithm. It is led by nurses, constructed by what we have built in our clinic for functional bowel problems that we use for benign origin. So we let, first of all, the nurses interview and treat with basic means, and then if needed, they can consult the physician, and if again needed, then they can refer to the gastroenterologist. But on top of this, we have identified specific subtypes of low anterior section syndrome, where we see that if you have, for instance, diarrhea dominant LARS syndrome, it is not advisable to go directly to the nurse, and then you need to be ruled out for the cause of diarrhea, and then we include our gastroenterologists. So in total, 1 out of 4 will also have a track with the gastroenterologist, and when they have this track, the gastroenterologists, they find at least one diagnosis in 4 out of 5 patients. And if you don't find that diagnosis for diarrhea and treat this targeted, then you will miss the treatment goal in the national clinic. So this is the basic idea.
That's phenomenal. I'm very interested about this LARS diarrhea phenotype, as you call it, because I think it's under-recognized and probably a little undertreated in our settings. What is the final diagnosis that they find 4 out of 5 times?
So they are ruled out in a standard way. It's not complicated gastroenterology, but it is actually they have a series of blood samples. They have stool samples to check for IBD, and then they are checked for small bacterial overgrowth with breath test, and they have a test for bile-acid malabsorption called the CAT scan. And we run patients through that program, and it is not complicated, but we should have the thought that there might be a reason for diarrhea that we should rule out. So basically these are the things. You also found patients with IBD in the cohort as well.
And how early, at 3 months is the earliest time point that patients are screened through this program?
Yeah, this is the earliest time point they are screened, but they have a possibility for direct referral to our clinic at any time point, and then a few patients are referred by clinicians from the region, often before or during the patient course as well. So it is not only patient screened, but it is also by referral from other hospitals and our own cancer clinic.
That's amazing. Are you doing at this clinic any preoperative counseling for your own patients?
Yes, we do. But this is we put a strong effort into this, but I'm not quite sure that patients will take it in preoperatively.
I agree.
The only thing they do, they become aware that there might be something,
yes,
and there might be somebody to help in the long run.
Yes.
I'm sure that they don't listen that much preoperatively.
It's too much information at that point. Yes. Tell us a little bit about the other 3/4 that go straight to the nurse-led program, and kind of what are the things in their armamentarium that they often offer. Is it a stepwise approach? Is it a tailored approach? What did you find in your study?
Yeah, it is a kind of stepwise approach, because the basic thing is patients, setting patients' expectation and educating patients in their new normal situation. Try to explain to them why how the rectum work and how the neorectum would work and why they have the problem. Because if they don't have a minimum of understanding what is going wrong, they are not able to change their lifestyle. And because the majority of what's happening in the nurse led clinic is not that I'm telling or my nurse is telling them what to do, it's what they do at home.
Yeah,
so if you don't teach the patient to, and you don't get them to incorporate the new knowledge, you will not succeed. So the basic part is actually patient education and motivation to do something different on their own.
Absolutely.
And then it is lifestyle corrections, diet, food intake, toilet positioning, getting rid of bad habits, use of stool blocking agents, use of loperamide, constipating agents, and a small volume NMS. So this is the basic thing. And then they are re-evaluated on a personal level. And then if they are not successful, they can either go for biofeedback, and minority of our patients go for biofeedback, but a large proportion will go for transanal ligation if they are not successful. So we can see in our cohort that roughly 2 out of 3 will stay on conservative measures. 1 in 3 would go to transanal ligation, and only 3% will go to surgery, mainly having stoma as a permanent solution or sacral nerve modulation.